Assalamu alaikum class. Today's topic is nutritional problems in public health. There are many nutritional problems which are prevalent in Pakistan, and these problems affect vast segment of our population. Some population segments are very vulnerable, especially the pregnant and lactating women and under 5 children. We will discuss the major nutritional problem today in today's lecture. In this lecture, nutritional problems in public health will be covered, and students will know the concepts of malnutrition and what are the types of malnutrition. Most important preventive strategies will be discussed regarding nutrition. The major public health importance are classified as low birth weight, protein energy malnutrition, xerophthalmia, which is the manifestation of vitamin A deficiency, nutritional anemia, which includes iron deficiency anemia and megaloblastic anemia. Then the iodine deficiency disorder will be discussed, endemic fluorosis and Lathyrism. Low birth weight is defined as birth weight less than 2500 grams or less than 2.5 kilogram. In this case, baby may be preterm or baby may be the case of intrauterine growth retardation. In both cases, if the baby weight is less than 2500 gram, we label that baby is low birth weight baby. In Pakistan, among children who had their birth weight reported or recorded, more than 1/5 had a low birth weight. It is reported in Pakistan Demographic Health Survey 2017-2018 that 22% of babies who are delivered and their weights have been recorded, they had a low birth weight. The problem of low birth weight is very prevalent in Pakistan. As we discussed in the last slide, that 22% of the babies had low birth weight, which means their birth weight was less than 2500 gram. When we compare this figure to the figure of developed nation, in developed nation, this figure is as less as 4%. So there are many causes regarding low birth weight, and these causes include maternal malnutrition and anemia, hard physical labor done by the women during pregnancy, some infections and illnesses during pregnancy, short maternal stature, very young age, high parity with very close interpregnancy or interbirth intervals, smoking, and most important among these causes is maternal malnutrition and anemia. Low birth weight is a significant public health problem regarding nutrition. The proportion of infants born with low birth weight was selected as one of the nutritional indicators for monitoring progress towards health of all by the year 2000. This shows the importance of this indicator. Since the problem is multifactorial, there is no universal solution. Intervention have to be cause specific. But the most important intervention should be improvement of maternal health or improvement of maternal nutritional status. We have covered vitamin A deficiency in previous lecture, and you are familiar with the term xerophthalmia. The signs of vitamin A deficiency are predominantly ocular, and these signs and symptoms include night blindness, conjunctival xerosis, bitoid spots, corneal xerosis, and keratomalacia. The term xerophthalmia or dry eye comprises all the ocular manifestation of vitamin A deficiency. ranging from night blindness to keratomalacia. Night blindness is due to the impairment in dark adaptation, while conjunctival xerosis is the first clinical sign of vitamin A deficiency. Now, I emphasize that night blindness is a symptom, while conjunctival xerosis is the first clinical sign of vitamin A deficiency. The conjunctiva become dry and non-wettable. Instead of looking smooth and shiny, it appears muddy and wrinkled. Bitote spots is another manifestation of vitamin A deficiency. These are triangular pearly white yellowish foamy spots which are present on the bulbar conjunctiva on either side of the cornea. They may be bilateral. Bitote spots in young children usually indicate vitamin A deficiency. The stage of corneal xerosis is particularly serious. The cornea appears dull, non-wettable, and eventually opaque. If there is severe vitamin A deficiency, corneal ulcers may result. The next stage is keratomalacia. Keratomalacia or liquefaction of cornea is a grave medical emergency. The cornea may burst open. So, it is very important to diagnose and treat vitamin A deficiency timely. This slide is the pictorial presentation of ocular manifestations of vitamin A deficiency. In this picture, you can see the bitote spot, corneal ulcer, keratomalacia. As I told you in the last slide, that vitamin A deficiency should be diagnosed and treated urgently because nearly all the early stages of xerophthalmia can be reversed by administration of massive dose 200,000 international unit orally on 2 successive days. So, it is very important to prevent the ocular health of community by administration of massive doses of vitamin A. The prevention strategies for vitamin A deficiency can be short-term, medium-term, and long-term. Short-term actions include administration of large doses of vitamin A orally in the recommended dosage to vulnerable groups on periodic basis. The medium-term action include regular and adequate intake of vitamin A in fortification of certain food like banaspati ghee or margarine or dried skim milk. The long-term actions include consumption of dark green leafy vegetable and other vitamin A rich food, promotion of breastfeeding, improvement in environmental health, immunization against infectious diseases, prompt treatment of diarrhea to prevent malnutrition, better feeding of infant and young children, which includes timely introduction of weaning food, improved health services for mothers and children, social and health education. Malnutrition is defined as pathological state resulting from relative or absolute deficiency or excess of one or more essential nutrients. This is the vicious circle of malnutrition and infections. Whenever there is inadequate dietary intake, the result is weight loss, growth flattening, decreased immunity, and mucosal damage. These factors will result in occurrence of disease, the incidence of disease increases, and duration and severity of disease also increase. It will in turn result in appetite loss, nutrient loss, malabsorption, altered metabolism, which result in inadequate dietary intake again. There are various types of malnutrition. Undernutrition is a state when insufficient food is eaten over an extended period of time. Overnutrition is the opposite. It is a state which results from consumption of excessive quantity of food over an extended period of time. Imbalance results from disproportion among essential nutrients, and specific nutrient deficiency means absolute or relative lack of essential nutrient. Different types of undernutrition is presented in this picture, and you must be familiar with these terms. Wasting means low weight for height, stunting means low height for age, and underweight means low weight for age. Protein energy malnutrition is identified as a major public health and nutrition problem. It is not only an important cause of childhood mortality and morbidity, but can lead to permanent impairment of physical or mental health. Protein energy malnutrition is due to an inadequate intake of food, both in quantity and quality. There are certain terms: kwashiorkor, marasmus kwashiorkor, and you must be familiar with these terms. Kwashiorkor is a manifestation of protein energy acute malnutrition. It is a severe form of acute malnutrition, and it is characterized by clinical signs including edema. Edema is present on the lower legs and feet initially, but it can spread to other parts of body. Other signs of kwashiorkor include cracked and peeling skin, changes in hair color and lightening of hair color presents, and lethargy and misery. While marasmus is another severe form of acute malnutrition, you can say it is another manifestation of acute malnutrition, and marasmic children or marasmic individual have the clinical signs of extreme thinness, often with flaccid skin, and you can say their appearance becomes old man appearance. Marasmic individual may be alert, but they are usually irritable. Marasmus and kwashiorkor are the two different manifestations of acute protein energy malnutrition. There are differences in marasmus and kwashiorkor presentation. In marasmus, muscle wasting is obvious. Fat wasting, there is severe loss of subcutaneous fat. There is no edema. Weight for height is very low. Sometimes the child is quiet and sometimes he or she is apathetic. Appetite of marasmus children is usually good. Diarrhea often present, and skin changes are usually none. Hair changes seldom we can see. Hepatic enlargement is not present. Serum albumin normal or slightly decreased, while urinary urea per gram creatinine is normal or decreased. The signs or symptoms which are always present in kwashiorkor are sometimes muscle wasting is hidden by edema or fat. Fat often retained but not firm. Edema is present in lower leg, but then it covers the other part of the body and usually in face and forearms. Weight for height is low, but this sign is masked by edema. The child is irritable, moaning, and apathetic. The appetite of child is poor. Diarrhea is often uh, present. Skin changes. There is diffuse pigmentation. Sometimes flaky paint, dermatosis is present. Hair changes include silky, easily pulled out hair, weak hair, sometimes due to accumulation of fat, hepatic enlargement can be seen. Serum albumin is low and urinary urea per gram creatinine is usually low. I think in this slide you can identify Marismus case and Kwashiorkor case. Protein energy malnutrition can be classified by Gomez classification, which is based on weight retardation, and it can be classified by Waterlow classification. When a child age is known, weight is measured, and it enables almost instant monitoring of growth measurement of height, which assess the effect of nutritional status on long-term growth. Gomez classification locates the child on the basis of his or her weight in comparison with a normal child of the same age. The formula of Gomez classification is weight for age is equal to weight of the child divided by weight of a normal child of same age into 100. The interpretation of this between 90 and 110%. We classify that the child is having the normal nutritional status. If the answer comes between 75 to 89, we classify as first degree mild malnutrition. Between 60 to 74%, second degree moderate malnutrition. Under 60%, third degree severe malnutrition. We have discussed in previous slide what is stunting and what is wasting. Stunting is low height for age and wasting is low weight for height. Stunting is due to chronic malnutrition and wasting is usually due to acute malnutrition. In Waterlow's classification, we measure height and we measure weight. When child's age is known, measurement of weight enables almost instant monitoring of growth, and measurement of height assess the effect of nutritional status on long-term growth. While interpreting these indicators, we take weight of the child as a numerator and weight of a normal child of same height as a denominator, and we calculate weight per height percentage and we multiply it with 100. While calculating height per age in percentage, we take height of the child as a numerator and height of a normal child of same age as a denominator and we multiply it again with 100. If the percentage of height per age is more than 95, then we label it as normal. If it is between 87.5 to 95, it is mildly impaired, or if it is between 80 to 87.5, it is moderately impaired, and if it is below 80, it is severely impaired as far as stunting or height per age is concerned. While in case of weight per height, if percentage is more than 90, we label that it is normal. If percentage is between 80 to 90, we say that it is mildly impaired and mild wasting is present. If it is between 70 to 80, we label that moderately impaired or moderate wasting is present. Less than 70 is severely impaired and severe wasting is present. Another method is to take mid-upper arm circumference. Arm circumference yields a relatively reliable estimation of body muscle mass. Arm circumference cannot be used before the age of 1 year. It remains almost constant between the age of 1 year to 5 years. An arm circumference which exceeds 13.5 centimeter is a sign of satisfactory nutritional status, while if it is between 12.5 to 13.5, it indicates mild to moderate malnutrition, and if it is below 12.5, severe malnutrition is labeled. If the dietary intake is low, then the body of the child adjusts to inadequate energy intake, and it is reflected in the measurement of arm circumference. If it is above 13 centimeter, it is a sign of satisfactory nutritional status. But if it is below, then we say that the child is suffering from malnutrition. For prevention and control of this public health problem, some actions at family level can be taken, which include health education of parents, promotion of breastfeeding, improvement in infant and young child feeding practices, and some actions like we can plan a kitchen garden, or we can promote keeping poultry to address the food insecurity. At national level, areas to be focused are rural development, agricultural production, stabilization of population, and addressing the explosive population growth, and some nutritional intervention programs should be implemented. And action at international level needs collaboration of FAO, UNICEF, World Health Organization, WFP. There is no simple solution of problem of protein energy malnutrition. Many types of actions are necessary which can be taken. The following are adapted from 8th FAO WHO Expert Committee on Nutrition for the Prevention of Protein Energy Malnutrition in the Community. These measures include measures which are directed to pregnant and lactating women, promotion of breastfeeding, development of low-cost weaning food, measure to improve family diet, nutritional education and health awareness, home economics, and family planning and birth spacing, and lastly, improvement of the family environment. Specific protection measures include that the child's diet must contain protein and energy-rich food, milk, eggs, fresh fruits and vegetables should be given to the child. Immunization should be done according to EPI program, and food fortification programs should be carried out like iodization of the salt. Protein energy malnutrition should be timely diagnosed and treated. To break the vicious circle of infections and malnutrition, early diagnosis and treatment of infection should be done, especially the infection which cause diarrhea, and we should develop the programs for early rehydration of children who are suffering from diarrhea, and development of supplementary feeding programs during epidemics should be carried out. Rehabilitation measures include nutritional rehabilitation services should be established, hospital treatment of malnutrition, and follow-up care must be there. The next nutritional problem which is of public health importance is anemia. Anemia is a condition in which hemoglobin content of the blood is lower than the normal as a result of a deficiency of one or more essential nutrients, regardless of the cause of such deficiency. There are two types of nutritional anemia. The first one is iron deficiency anemia, which results from inadequate intake, poor bioavailability of dietary iron due to problems from intestinal absorption, and due to excessive losses of iron from the body, such as in menstruation or after childbirth. The second type is megaloblastic anemia, and it is usually seen in poor income groups. During pregnancy, a woman is vulnerable to be anemic. Some infections like malaria and hookworm infection predisposes to anemia, and anemia causes a significant impairment of the maximal work capacity. What intervention we can do? If the hemoglobin is between 10 to 12 gram per deciliter, daily supplement with iron and folic acid tablet is advised. If it is less than 10 gram, the patient is referred to the nearest primary healthcare center. Iron and folic acid supplementation should be given. One tablet of iron and folic acid containing 100 mg of elemental iron, which makes 300 mg of ferrous sulfate and 0.5 mg of folic acid, should be given to anemic patients. Iron fortification of foods and other strategies must be implemented. Another problem of public health importance is iodine deficiency disorder. Iodine is essential for thyroid function and for physical and mental development. Daily use of adequately iodized salt is the best strategy to overcome iodine deficiency disorder. Across Pakistan, almost 4 out of 5 households consume iodized salt. Deficiency leads to much wider spectrum of disorders. Iodine deficiency is prevalent in some areas of Pakistan. To control this public health problem, there are 4 essential components of National Goiter Control Program. These are iodized salt or oil, monitoring and surveillance, manpower training, and mass communication. The level of iodization is fixed and is not less than 30 ppm at the production point and not less than 15 ppm of iodine at the consumer level. The next element is iodine monitoring. Iodine monitoring should be done to determine iodine excretion and to determine iodine in water, soil, and to determine the iodine content in salt for quality control. In Pakistan, lady health workers can communicate the message about the benefit of using iodized salt. So, manpower training is must. And for mass communication, use of mass media to promote iodized salt consumption is necessary. Endemic fluorosis is another public health problem regarding nutrition. In many parts of the world where drinking water contains excessive amount of fluorine, which is between 3 to 5 mg per liter, endemic fluorosis has been observed. There are 3 forms or 3 manifestations of fluorosis. The first is dental fluorosis, which is the most common, in which we see mottling of teeth, white patches on enamel become yellow, and then later on brown or black discoloration can be seen. In severe cases, loss of enamel gives the teeth a corroded appearance. The second type is skeletal fluorosis. Skeletal fluorosis is due to heavy fluoride deposition in the skeleton, which can lead to disability if not treated properly. The third manifestation is genu valgum, which is the osteoporosis of the lower limb. For prevention and control of this public health problem, some intervention can be useful. The first intervention is changing the water source. If any water source has higher content of fluorine, the people should opt another water source which contains the suitable amount of fluorine. The next option is chemical treatment, water can be chemically defluoridated, and the other measures include fluoride supplements should not be prescribed if there is problem of endemic fluorosis in the community, and use of fluoride containing toothpaste should also be avoided. The last nutritional problem to be discussed is Lathyrism. Neurolathyrism is a crippling disease of nervous system characterized by gradually developing spastic paralysis of lower limb. It is due to consumption of some pulses known as Lathyris. Lathyris is a good source of protein, but for its toxin which affects the nerve, it is harmful. If somebody takes diet which contain this dal, and if he or she takes over a period of 2 to 6 months, neurolathyrism results. Now I discuss some of the interventions which can be opted. The first intervention to deal this problem is vitamin C prophylaxis. To repair the damage, vitamin C can be given in the dose of 500 to 1000 milligram daily for a week. The next is banning the crop. The third one is removal of toxin, which can be done in two ways: by soaking the pulse in hot water or by parboiling process. Health education should be provided to community. Genetic approach can be opted to develop a crop which is less harmful or which has no harm. Thank you very much.